Dr. Elona Turley is on the faculty at the University of Alberta. She's Canadian, and she has kindly migrated southward to give a talk. She was our most recent Special Coagulation Laboratory Fellow, and I want to mention that we do have a fellowship in the Special Coagulation Laboratory. We also have a clinical fellowship, so if you have persons or trainees interested, talk to Dr. Anil Ashrani. He is our education director. Dr. Turley, please. Thank you.
Thank you, Dr. Nichols. And welcome back. I hope you're all adequately refreshed after the break. It's great to be here in front of you today, and I must admit an honor and humbling to be presenting alongside with my teachers and mentors from last year. And so I'm going to be talking about lupus anticoagulant today, and specifically an overview of the laboratory diagnosis with a few case studies spotted in. This can be a huge topic, but in the interest of getting you back out into the sunshine, and myself as well, I'm going to keep it focused and give a very high-level overview of the topic. I have no relevant disclosures, nothing to disclose. So let's start off. What is a lupus anticoagulant? Well, the phenomenon was recognized for several decades before this, but the term was coined in 1972 to describe an inhibitor of coagulation that was found in patients with lupus. We now know that a lupus anticoagulant is neither an in vivo anticoagulant, nor is it specific to patients with lupus, but we're stuck with the name. What we do know is that a lupus anticoagulant consists of autoantibodies, and these autoantibodies inhibit phospholipid-dependent coagulation in vitro. And these autoantibodies are directed against a phospholipid-binding protein, usually beta-2 glycoprotein 1. And this beta-2 glycoprotein 1, when it's bound by these autoantibodies, this binding results in enhanced phospholipid binding, and these phospholipids are pulled out of the laboratory test system and can't participate in the laboratory clotting time. So the end result is a prolongation of your in vitro clotting times. You've seen this before this morning. Just to look again at this simplified model of coagulation in vitro, you've got your APTT that reflects your intrinsic and common pathways, your PT or INR that reflect your extrinsic and common pathways. Several phospholipid-dependent steps are in there. Major ones are your conversion of 10 to 10A and your conversion of prothrombin to thrombin. And so if the lupus anticoagulant is just this in vitro phenomena, this in vitro thing, why do we care about it? Well, this audience knows well that the diagnosis of a lupus anticoagulant is one of the criteria for diagnosis of the antiphospholipid antibody syndrome. As has been previously mentioned, the lupus anticoagulant detection of a lupus anticoagulant that is persistent, greater than 12 weeks, or detected greater than 12 weeks apart on 2 occasions, will fulfill the laboratory criterion. The other laboratory criteria includes detection of anticardiolipin or anti-beta-2 glycoprotein 1 antibodies of IgG or IgM class at moderate to high titer. And then you have your clinical criteria, which you also must fulfill either in terms of the thrombotic events or pregnancy morbidity. So how about the epidemiology of the lupus anticoagulant? So about half of patients who were studied with antiphospholipid antibody syndrome have a lupus anticoagulant at diagnosis, and 12.1% of those patients had a lupus anticoagulant without evidence of anticardiolipin antibodies. So in these patients, it was the lupus anticoagulant that clinched the diagnosis of antiphospholipid antibody syndrome. In lupus, in patients studied for 5 years, 31% of patients develop a lupus anticoagulant. And this is clinically relevant because they found in the study that those patients with a lupus anticoagulant, after 20 years, 50% of them had developed a thrombotic event. And certainly asymptomatic individuals without autoimmune disease, without thrombotic events, can also be found to have lupus anticoagulants. Often these are transient, but it really, what the prevalence and incidence of this is, really depends on how you test and who you're testing. But certainly can be detected in patients, but usually considered to be a fairly low incidence and prevalence. So I'm talking about the laboratory side of lupus anticoagulant diagnosis. And despite the fact that this is clinically important, essential for diagnosis of antiphospholipid antibody syndrome, the laboratory diagnosis remains really challenging. And there have been some publications over the years looking at external quality assurance survey results, proficiency testing results. How are the labs doing? And it shows that there are still some real difficulties. In particular, labs struggle with weak lupus anticoagulants and as well false positive results, and as a result of numerous interferences in these assays. And there are lots of reasons for the difficulties and lack of conformity in how the labs perform these assays. Big problem, there's no gold standard. What defines test accuracy? We don't have a gold standard test or way to test for lupus anticoagulant. Different assays that you use have different sensitivity. Different labs may select a different approach and different assays to use, and even a couple of labs testing with the same assay may have different sensitivities. There are variable adherence to the guidelines by different labs. And even labs who are following the guidelines, what they're doing actually depends on which guidelines they follow. There are some differences between the laboratory guidelines for lupus anticoagulant diagnosis. And then, of course, there's this new challenge that Dr. Pruthi talked about that affects coagulation labs in general, but lupus anticoagulant testing certainly is not immune. These direct oral anticoagulants have really given a new challenge to lupus anticoagulant diagnosis. So I mentioned some of the guidelines. There are different bodies that have put out guidelines. These are the most recent editions of the guidelines that have come out. ISTH published theirs in 2009. The British guidelines were published most recently in 2012, and the CLSI guidelines are the most recent, published in 2014. And now when you look at the dates of publication of these guidelines, and think about when the direct oral anticoagulants started coming on the market, you might guess it's actually only the CLSI guidelines that address lupus anticoagulant diagnosis in the face of these anticoagulants. There are many similarities between the guidelines, but other variations as well. One of the big ones you'll hear about and pick up on is the sequence of testing. So in the CLSI guidelines, they start with the screen, then go to the confirm for phospholipid dependence, and then perhaps a mixing study. The ISTH and British guidelines start with the screen, then do the mix to show inhibition, and then go to the confirm step to demonstrate phospholipid dependence. Other variations between the guidelines include whether to do the mixing step at all, whether it's necessary. And if you go to and look up these guidelines and look at letters to the editor associated with these articles, you'll find a slew of discussion surrounding yes or no, whether different feelings people have on the necessity of the mixing step. Also some differences in terms of how you calculate the ratios, the denominators used, which reference intervals are picked. And those are beyond the scope of the discussion today, but by all means, if you're interested, have a look. So I'm going to sort of take you through the criteria or process for lupus anticoagulant diagnosis using the CLSI guidelines or approach as a backbone. So the diagnosis starts with procurement, and you got to think about the patient you're selecting for testing, and as well think about the specimen that you're going to test on. And then you've got your actual testing in the lab using your screen, confirm, and mix steps. Then you've got to think about your results and evaluate and exclude for other things that could be causing these results. And then finally, there's the interpretation and reporting of the results and rendering that final conclusion. So in terms of procurement and your patient considerations, you want to test the right patient at the right time. So who is the right patient? Is testing appropriate for your patient? Really, these tests aren't perfect. They're not even close to being perfect. So you want to make sure your patient has a reasonable probability of having a lupus anticoagulant to begin with. Testing people out on the street at random isn't going to work. And actually, the ISTH guidelines include some specific recommendations of patients that they suggest testing would be beneficial in. So how about the right time for testing? Well, we've talked about a few of these situations. So maybe what is the wrong time? So in terms of anticoagulation therapy, that's the wrong time. Ideally, you'll test before the initiation or after cessation of anticoagulant therapy, just because of these interferences. And as well, the lupus anticoagulant testing is clot-based, and so subject to numerous interferences during the acute phase, such as elevations in factor VIII, fibrin degradation products, and platelet microparticles that are circulating as well can give you some false negative results. So how about the sample? Strict adherence to the standards for proper specimen collection, handling, and processing are absolutely critical for lupus anticoagulant testing. The sample that you collect should be processed promptly to platelet-poor plasma using a double centrifugation procedure to achieve a platelet count less than 10. And when you think about it, if you're doing a mixing step with normal pool plasma, your normal pool plasma that you use also has to meet that target, or else if you've got too many platelets in there, you're going to give that test a dose of phospholipid that you don't want to give it. So I'll give you a case to illustrate this. So this is the case of a 35-year-old female, and this is a referred-in sample. So we don't know where it came from, but it didn't come from us. So her APTT was normal at 35 seconds, INR normal at 1.0, and the DRVVT screen ratio is normal at 1.1. So how do you interpret this? Who thinks it's negative for a lupus anticoagulant? Raise your hand. Who thinks it's positive for a lupus anticoagulant? Raise your hand. Who thinks this is too simple for what I just described and we need more information? Right, so if you got these results and, I hadn't maybe given you some clues, you'd probably say lupus anticoagulant not detected, write it off and move on. This is great to get. But then you get the phone call from the clinician. I don't buy this result. I don't buy it. This patient has a history of unexplained ischemic stroke, 35 years old, and actually this is a confirmatory lupus anticoagulant testing because she was lupus anticoagulant positive 13 weeks ago. Further to that, her anticardiolipin titer was greater than the 99th percentile, and in fact at her home institution, her PTT was persistently elevated, and even, the day before this lupus anticoagulant testing was sent. What gives? So, a little bit of digging and a few phone calls. It turns out that this outside institution had gotten their procedures mixed up. Instead of using their procedure for platelet-poor plasma or platelet-free plasma, they used their platelet-rich plasma procedure. That sample was then frozen, transported, thawed, and then we tested it as usual. So what happens when you freeze a bunch of platelets in plasma? You get a nice healthy dose of phospholipid, you overwhelm and quench your lupus anticoagulant, and basically you do an auto platelet neutralization procedure. And so recollection with proper procedures, in this case, would prove the persistence of the lupus anticoagulant. Bottom line, pre-analytical issues, your specimen, your patient, they matter. Don't ignore them. So moving on to the laboratory testing steps, the screen, confirm, and mix steps. So screening, what's recommended is doing a maximum of 2 different screening assays. If you do more than 2, you increase your risk of false positives. If you do only 1, the test you're using might not be sensitive to lupus anticoagulant and you could miss it. It's recommended that you select tests that are based on different principles in different areas of the coagulation pathway. Typically, the first-line tests selected are the dilute Russell Viper venom time, and then usually a lupus-sensitive APTT or something else based on the intrinsic pathway. In terms of the confirming, demonstrating phospholipid dependence, and then the mixing steps, the confirm and mix steps, if you're performing them, should be performed on the same assay that was abnormal in the screening test. So if your PTT was abnormal, but your DRVVT was normal, you wouldn't go on and do your DRVVT confirm and your DRVVT mix and omit further testing of your PTT. And then the mix or not to mix, that is a question, but not a question for today. So just back to our to our coagulation cascade and lupus anticoagulant assays, where do they hit? So your APTT obviously starts at the top of the intrinsic cascade. Your silica clotting time, SCT, in brackets, is similar. It's an intrinsic-based test, basically based on the APTT, but using a silica activator. And so, in contrast, your DRVVT will test at is an activator of factor 10 and looks at the common pathway. And when you look at the coagulation cascade and where these tests hit, you've got to remember that anything downstream of where your assay activates is going to affect your test. So the nice thing about the DRVVT is that it's downstream of factor 8. So factor 8 deficiency, factor 8 inhibitors aren't going to affect your DRVVT, whereas your APTT-based assays, in contrast, can reflect everything downstream, so there's often a lot more room for interference there. So I've talked about the screen, confirm, and mix. How do those apply to the tests? So just as an example, so that screening step performed on patient plasma, if you're going to an APTT-based system, you might use a lupus-sensitive APTT. For a confirmatory step, you might use the platelet neutralization procedure, which was discussed previously. And then for a mixing step, you can do a one-to-one APTT mix. Whereas if you're using the DRVVT as your test, you have your DRVVT screen, your DRVVT confirm with the addition of phospholipid, and a DRVVT mix. So what are the advantages and limitations of an APTT-based system? Of course, the APTT, we're familiar with it. It's cheap. It's fast. APTT mixing studies can be performed routinely and are often available, around the clock at many institutions. So if you're trying to figure things out at 2 in the morning, that can be helpful. And then in your lab, you can select PTT reagents that are sensitive or insensitive to a lupus anticoagulant according to your according to your goals of lupus anticoagulant detection. So if you're in a quaternary hospital where lupus anticoagulants are nuisances that lead mostly to delays in procedures and unnecessary testing, then you might want to pick one that's less sensitive. If you're in a coagulation lab and you're doing a lot of lupus anticoagulant testing, well, then you'd want one that's more sensitive. That power of variable sensitivity can also be a limitation because you might miss or detect too many depending on your reagent when you don't want to. Another disadvantage is the fact that with the APTT itself, there's no built-in confirmatory step. And so the platelet neutralization procedure is usually an in-house assay, and it takes a lot of expertise and skill to get right and to do well. There are some alternative assays and kits, like the silica clotting time, the stay clot assay, that are based on the APTT principle, but include a confirmatory step. And then, of course, another major limitation of the APTT is that anything that interferes with the PTT can interfere with your lupus anticoagulant testing. How about the DRVVT? We don't do as many of those as we do with the PTT, but we still have a pretty lengthy experience with the test. There are commercial kits, and many of those commercial kits contain heparin neutralizers. As I mentioned, the reactions are independent of factor VIII inhibitors or activity because it's downstream. Limitations, even with commercial kits, the kits you get, the sensitivities can be variable, and how people use and employ the kits can also vary. And there are lots of interferences, especially from anticoagulants, as well as some other challenges. So what about other tests? Even if your DRVVT and your APTT-based assays are recommended up front, guidelines haven't completely written off other tests. You might not use them as screening tests, but sometimes if you have them in your arsenal, they can be helpful to use when you have a high suspicion of a lupus anticoagulant and you think you might not be picking them up. It just depends on talking to your lab and seeing what they have and what's validated and what your options are. So how about that exclude evaluate step? This comes down to, can you trust the results you're getting? And what do you need to know for this? You need to know your tests. What tests is it that your labs are doing, and what are the limitations of that test? And then you want to look at your results, and you need to know what patterns are seen with specific interferences. And sometimes this isn't something you can get from a review article. Sometimes it really comes down to familiarity of the operator and the people who interpret these tests on a daily basis. And then it helps to know what other tests you have available in your lab. What are your lab's algorithms to try and tease out what other interferences or what else could be causing this result. You might do a thrombin time and a reptilase to look for your direct thrombin inhibitors or heparin. You might go to factor assays or inhibitor screens, do a fibrinogen D-dimer, or you might, as I mentioned, go to additional lupus anticoagulant assays. So you got to know your tests, and you also got to know your patient, like that physician. That result didn't make sense to him. You got to ask yourself, does this result make sense? Is it really not what you were expecting? What's the clinical history of this patient? What was their presentation? Are they bleeding? Are they clotting? Are they on any anticoagulants? So going to, Dr. Pruthi talked a lot about the anticoagulants, but in terms of testing for lupus anticoagulant while on anticoagulants, in general, if you can avoid it, that's best to do. For your heparin, as I mentioned, some of the commercial kits contain a heparin neutralizer, but you got to know what the limitations of your heparin neutralizer are. Some kits will only neutralize prophylactic concentrations of heparin, whereas some will neutralize up to 1 unit per ml. And then if you're in excess of that, that's going to affect your results. As in terms of warfarin, we know that warfarin decreases both the sensitivity and specificity of lupus anticoagulant testing, and that the interference basically progressively, it gets worse as your INR or prothrombin time increases. There have been some advocates of modifying the assay and doing it on a mixed sample to replace the coagulation factors that are missing, but if you're mixing your sample, you risk diluting out a weak lupus anticoagulant. Many labs don't actually do this step either, so it's worth knowing what your lab's procedure is in these cases. Basically, when it comes to testing on warfarin or heparin, ideally avoid it, but if you can't or there's a problem there, I'd approach results with a healthy dose of skepticism. And then in terms of the direct thrombin inhibitors and the direct 10A inhibitors, these are notorious for causing false positives. Avoid testing while on these drugs. So this is a case of a 55-year-old woman with a recent clot. Her APTT was normal. Her INR was mildly elevated. Her thrombin time is normal, so not on any direct thrombin inhibitor or heparin. And then let's look at her DRVVT results. So her screen is elevated. Her mix doesn't correct. There's an inhibitor there. And her confirm is also elevated due to phospholipid dependence, right? So who thinks that this patient has a lupus anticoagulant? Raise your hand. Who would say this is lupus anticoagulant positive? Who would say this is indeterminate, lupus anticoagulant indeterminate? Okay. Who would say this is lupus anticoagulant negative? Who would say there must be more to this story because I'm showing it right after a slide about anticoagulants? So this could be a number of things. It could be a lupus anticoagulant. That would be reasonable, but as this step would tell us, we need to rule out other causes. And so another pattern that this could reflect is actually the effects of warfarin and a false positive result in warfarin, sure. But at my institution, this is how I typically see the direct 10A inhibitors behave. And this might not be how they behave at your institution, but after seeing a lot of these, this sort of got my spidey senses tingling that there might be something going on. And so, in fact, an anti-10A level done in this patient was consistent with circulating direct 10A inhibitor, and a phone call also showed that the patient was on rivaroxaban at the time of testing. Okay, so the final step is reporting, and reporting an interpretive comment with numerical results. So let's demonstrate why this step is important with a case. So this is a 45-year-old male who comes to see you in clinic. He brings you a napkin, and he had jotted down these letters and these numbers from his institutional patient portal. And he says, this is my lupus anticoagulant testing. You know what these mean, right? So look at these results. Does he have a lupus anticoagulant? Who says yes? Would you tell him that? Who would tell him he does not have a lupus anticoagulant? Who would say, find me your original, like your full testing report? I can't interpret based on this. So when it comes to interpretation and reporting, the entire panel of raw data should be interpreted by an experienced and qualified individual. That final report should indicate a summary of the lupus anticoagulant status, whether it's present, not detected, or indeterminate. Recommend any additional tests or follow-up. If the test is positive, recommend that repeat testing after 12 weeks. And then include the reference intervals and cutoffs with that numerical data. So fortunately, in this patient's chart, the results, the full report was found, including the reference ranges and a comment that said lupus anticoagulant was not detected by both the DRVVT and silica clotting time-based tests. So for this patient, we actually spared him the expense and poke of additional testing. You don't have to test him again because, unless there was another reason, but this test was negative. Okay. So I just wanted to make one note on, though I talked about lupus anticoagulant, on the other antiphospholipid antibodies, anticardiolipin and anti-beta-2 glycoprotein 1 testing. It's recommended that these be tested along with lupus anticoagulant. There's clinical relevance to this in that in patients who are positive for all three, there's an argument of a higher thrombotic risk in these patients. And actually, in patients who are triple positive, there's a greater persistence of that positive profile. Patients who have all three tests positive have a 98% of them are positive on repeat testing after 12 weeks versus 84% who have 2 of 3 tests positive versus 40%, only 40% who have only 1 test positive. And then from a laboratory perspective, it's nice to have because these are serologic tests not based on clotting times. So in summary, lupus anticoagulant diagnosis is important, but lots of challenges to diagnosis. We don't have a gold standard test. We do have guidelines, and these guidelines state that good results for testing start at the source with a proper selection of patients, and your specimen needs to be of quality. And then the proper testing continues with the lab. So your lab should have adherence to guidelines and a good sensical approach to testing. That their approach should include appropriate interpretive reporting of your results. And you want to make sure your lab is of quality. Pick a good lab if you can pick your lab. And basically for you as the clinician, an awareness of these issues is essential to properly apply the results clinically that you're getting and to follow up the results appropriately as well. And I hope I've given you today a bit of an overview of that to give you that awareness. Thank you.